Hey, how's it going?
Hey, what's up, Sri? Good afternoon, guys. All right, I think we got a quorum. Let me get my screen up here. Okay. All right, guys. So let's see. Our topic today is lumbar interbody fusion techniques. Get this thing started here. We'll make this informal, so any questions, just interrupt me. We're going to go through how I think about which patients are the ideal candidates for any type of interbody. We'll go through some surgical techniques. We'll talk about risks, complications, and we'll use some evidence-based literature to make our points as well. These are my disclosures. The only relevant disclosure is that I receive royalties for a T-lift cage, the titanium PL that you guys have seen me use, or I'm in the hospital. So, but we'll keep it on as unbiased as possible in terms of the indications for each of these interbodies. Okay, so what I want you guys to take away from the talk is that there's always a risk-benefit ratio for any of the interbodies that we decide to do for patients. And that goes for anterior, oblique, which we're not going to talk a lot about, lateral, and then finally the posterior interbodies. Just a quick note about obliques. We don't really do that here a ton. It's a slightly variation in between an anterior and lateral approach. The real indications are like at L4-5 and L5-S1 if you're doing both levels at once. But if you're not doing both levels at once, then there's not a huge advantage over a lift or a lateral, in my opinion. And we don't do a lot of back pain surgery here at Northwestern, so that's why you don't see a lot of it here. This is a patient where you're going to have a lot of variations at Spine Indications Conference as to what to do. This is an L4-5 degen spondy, got a mild coronal plane deformity, severe stenosis at L3-4, L4-5, and this patient has neurogenic claudication. If you look at the AP and laterals, there clearly instability in the sagittal plane, a little bit of scoliosis, not a ton, but it can go into your algorithm. So what are the drivers of debate? Well, we want to achieve our goals of surgery, which is number one, solid arthrodesis, and number two, optimize your clinical outcome. Second, we want the patient to be satisfied. And so that satisfaction is predicated on a good outcome, but also a minimization of complications. You have to realize that no two degen spondies are alike. So we'll go over the characteristics that may sway you one way or another. This is my algorithm when I think of degen spondy. This is just one type of pathology that we deal with on a regular basis. So a lot of these patients don't need surgery, we know that. But if you decide to do an operation, we can divide patients into a decompression and fusion versus just a decompression. We know that we can just do a decompression alone in some individuals. There are interspinal spacers as one type, MIS, open type of decompressions. If we use a fusion, we can choose the instrumentation or no instrumentation. We can still do PLIFs without any instrumentation, although we don't do a lot of those just because of the ease of instrumentation nowadays. And finally, we have a ton of other options, including A-lift, lateral, T-lift, and then we'll group T-lift and PLIF together because most of us do T-lifts in 2021. Well, why do we fuse? And I'll ask you all these questions in clinic over and over and over again. We have to realize that there's not a whole lot of evidence as to why we fuse. There are a lot of theoretical benefits. There are a few studies that show advantages, but we have to know that overall, that there the evidence is really suggestive that these fusions will lead to. These interbodies will lead to increased fusion. So we do fusions because we want to reduce osteoarthrosis. We think that solid fusion does influence outcome, especially in patients who are younger, because the ability to have osteoarthrosis become symptomatic is an issue when there is a lot more time after surgery. And then finally, additional risk factors for fusion also come into play. There are variations in degen spondy, including disc height. So somebody with a very tall disc may not benefit as much from an indirect decompression. We've talked about that in conference. fluid in the facet joint. There can be dynamic instability that makes a patient need an interbody more if they're moving back and forth on flexion extension views. Positive sagittal balance will lead us towards an operation that will create more lordosis versus the flip side. Obese patients will tend to think about minimally invasive applications a little bit more than an open, solely because there are more risk to open cases in these patients. And then finally, or not finally, but activity level can also affect whether you include an interbody. I would say the more active patients, I'm thinking about more surgery, more surface area, higher level of fusion than one with just posterolateral alone. And then finally, someone with back versus leg pain, we may want a direct decompression along with the indirect interbody effects if somebody has significant leg pain versus back pain. So this is how I think about the continuum of treatment for somebody with degenerative spondy, and it goes by age. So if you look at it by decade, the younger patients, I typically do a more robust surgery, and the middle of the road, I would say, maybe a more minimally invasive, even cortical screws. And then the older patients, I'm trying to get away with as little as possible, because we know that patients in this age group, over 85, the clock is ticking when they're under anesthesia. So you really want everything you decide to do for that patient has a much greater opportunity cost, and so that definitely goes into the decisions and play. But with each of these decisions comes a cost, and it comes at a cost of complications that we'll go through for each procedure. So we can't make these decisions haphazardly. We have to think about them we have to think them through, and we have to come up with an algorithm that will work for every patient that walks through that door. When to do what? Well, it depends on one's age, their laterality of symptoms. If they have bilateral symptoms versus just one side, I'm thinking one type of interbody versus another. What type of pathology they have, the number of levels of surgery, the severity of their stenosis, and then finally the patient wishes. Whenever we talk about the options, we don't just give them one option. We give them a couple of options. We certainly have a bias in terms of how we sway in terms of our own opinions as what they should have, but we should incorporate the patient into the decision-making process. So we add interbody largely because we want to increase fusion rates, and that's the bulk of the evidence can show us. The other types of theoretical benefits may not come to fruition when we look at the evidence-based literature. This study is a meta-analysis that looked at 8 different studies with over 1,000 patients and looked at all interbody fusions versus posterolateral fusions. And not surprisingly, if you have a interbody fusion, you have a greater rate of fusion, but that should actually say greater blood loss. There's more surgery, so there's more potential complication, there's longer operative time. But in the end, there's really probably not a whole lot of difference in pain, function, and return to work. We have some recent studies that may show that interbody fusions may be more cost effective the longer you go out with your outcomes, but that's really dependent, or that's incorporating the reoperation rate. I think if you have a high reoperation rate, that's going to cost more, and naturally that's going to cost more money, and that comes down to the fusion rate or the increased fusion rate for interbody fusion. These other reasons I think apply, and we're going to talk about how they can affect certain patients, but we simply do not have the evidence to show across the board that they are widely applicable. And the reason is because the studies that we have really aren't designed to look at large numbers of patients with deformity, or large numbers of patients with a dynamic instability, or large numbers of any of the other criteria that we talked about. Most of our studies look at all comers, and when you bring in all comers, you're at the whim of what comes through your door. And most people who come through your door will not have one of these characteristics that we believe may make one patient a better candidate for an interbody versus something else. So, in my opinion, interbodies are much better at correcting deformity if that is one of your objectives. You increase stabilization immediately. So certainly a dynamic instability patient may benefit from interbody. you're going to get more lordosis. Whether that leads to an outcome difference, we've shown that in deformity, but in degenerative patients, I don't think it's been clear. And then whether or not there's a better outcome, probably not for all comers. The candidates in my mind are the younger patients who need a more robust fusion, who have a greater chance at having a symptomatic pseudoarthrosis, somebody with an associated deformity. If you do MIS surgery, I think if you don't do interbody, you're really asking for a pseudo, because that's the best way to get a fusion is to add an interbody, and I think that's what allows us to do MIS surgery is the interbody setting. And then finally, someone with a non-union risk, smoker, diabetes, osteoporosis, these kinds of characteristics. Why do we do an ALIF? Well, there are a few reasons why, and it's really largely because we want to recreate lordosis. And there's no question that with the evidence that we have available that ALIF is the most lordotic producing interbody fusion that we have to offer our patients. Outcomes, adjacent segment disease, that's a little bit questionable. There is a theory that if you go in the front and don't go in the back, you don't disrupt the facets and you have less adjacent segment disease. I think there are studies that show either way, or show both an improvement and then no difference. And we talked about this before that L4S1 contributes about 60% of your total lordosis. So if you want to recreate lordosis for a patient, you don't want to fuse them in a flat level, your ALIF is your best bet in terms of recreating the lordosis that the patient was born with, instead of that's lost over time. The reason why we can recreate lordosis is because the patient is supine during the surgery. So we have a better opportunity to reduce a spondy. We can use the gravity to our advantage. We have a wider annulotomy, so a better release of the disc. And we can better mechanically manipulate this level anterior compared to lateral and posterior. There's no question that we can do that just because of the exposure, because of the biomechanics, because of the positioning of the patient. And so I certainly try to do this in a setting where I need to get a fusion, like a younger patient, and in one who I want to create lordosis in. When we do this operation and we take out the disc, all we need to do is use a few instruments in order to manipulate it. We can increase disc height, we can increase foraminal height in a way that's very powerful and can obviate the need for a posterior procedure if that patient does not have central stenosis. And I do a lot of these for folks with foraminal stenosis. This comes to the point if somebody has bilateral symptoms with bilateral foraminal stenosis, maybe a better candidate for an ALIF versus a TLIF, which is really just targeted at one foramen, unless you do facetectomies on both sides, which may take a little more time. This is one study to indicate that anterior surgery recreates lordosis. This is done by the Watkins group, where they looked at patients who had an anterior, lateral, and transforaminal fusion. It was a radiographic study and concluded that anterior significantly improved lordosis more than the comparator lateral and TLIF. Anterior and lateral also had significantly increased disc height, which is not a surprise when we talk about doing a lateral type of procedure. But a TLIF may be more advantageous because it's just a single position, and you're probably doing a quicker surgery because you don't have to turn the patient. This is another study done at Northwestern by Patrick Shea, looking at ALIF versus TLIF and concluding that ALIF is superior to TLIF in restoring foraminal height and lumbar lordosis. So I think this is a fact. I don't know if there's a whole lot of folks who can argue against this being true, especially in the hands of surgeons who are good at both. I don't care how good you are at doing a TLIF, you're going to have a challenge to match the biomechanical characteristics of foraminal height and lordosis when you compare it to doing anybody with an ALIF. But there's a cost. An anterior approach, especially in our institution, involves a vascular surgeon. And these are the types of complications that are unique to this approach that a posterior only patient will not be subject to. So you got to be sure that whatever advantages you're getting from the anterior and whatever exposure you're giving this patient to these complications is warranted. And so all of these complications are low, I would say. But in the case of something like retrograde ejaculation, which I'll talk about in a sec, that this affects young males, and you have to have a long conversation with individuals who are in that age group. There are some surgeons who choose not to even consider an ALIF in a young male. I'm not one of those, because I think if a patient comes into the conversation and understands that that is a risk, albeit low, and they understand the advantages of an anterior approach, and they understand the reasons why I would like to still do it for them, then I think it's a risk worth taking. Anterior lumbar surgery involves dissection of the sympathetic plexus. And so when we're doing the exposure with a vascular surgeon, the good ones you'll see will not do any more exposure than we need, except just over the disc. If you go too far lateral, if you are too far off base, you're going to hurt some structures in the area that really you shouldn't even have to see for exposure that we need. Vessel injury, fortunately, is very rare, but in individuals who have it, there can be a potential huge complication, blood loss, a loss of pulses to the foot, numbness and tingling, and these things can happen, after a permanent vessel injury. For the most part, these injuries are amenable to primary vascular repair, and these patients recover without incident. But again, this is a complication that is unique to this approach. Oftentimes, if I'm thinking about an ALIF, every time when I'm thinking about an ALIF, I will be looking at the preoperative MRI and helping the vascular surgeon determine whether or not the anatomy is amenable to a anterior approach. So in this setting at 5-1, when you have a bifurcation at the level where you're going to do your ALIF, this portends of better prognosis and a quicker exposure and less rate of complications. But then you can see an individual like this where the vessel is right over the L5 S1 disc space, and there's really, you can create room here and create a space, but this is going to come at a cost. So I will be a lot less likely to recommend an anterior surgery for this individual than the one before. Ureteral injury, again, very uncommon, but it's a much higher rate in revision surgery. We typically think about going in the front as one and done. And that's one of the reasons why lumbar disc arthroplasty doesn't make a lot of sense, because if you do a lumbar disc arthroplasty for an elective procedure and there's something that goes wrong with it, going back in through the front again is a life-threatening operation with all of the complications that come from revision. And ureteral injury is one of these issues that's much higher in revision. In individuals who need a revision, we consider a pre-op stent placement to locate the ureter. And if this happens, urology is usually on board and can primarily repair it. VTE is a higher risk in an ALIF than a posterior procedure, in my opinion. This can be secondary to vessel manipulation. In most spine surgeons around at this institution, we're still not routinely hemoprophylaxing these patients who have an anterior, although this is the type of patient that I would think about it just because of the higher incidence. Risk factors listed here does increase your risk. You may want to consider a filter placement preoperatively. But again, the decision for pharmacologic prophylaxis is purely individual and not a lot of evidence to support one way or the other. Retrograde ejaculation occurs. The most common rate that's cited for patients is about 4%. I think it's much lower than that, especially in our experience here at Northwestern. And I think the 4% number is a more archaic number in terms of that includes transperineal. So I do tell patients 4%, but I also tell them that they're very. I don't think I've ever had an individual with this complication, or if I have, no, they haven't said it. So that's why I'm always saying that we're not really sure what the incidence is because it may not be reported by the men who have the complication. If you look at the historic incidence of retrograde ejaculation, the transperitoneal approach certainly was a much higher rate. I mean, 20, 30, 40%. I can't even imagine anybody signing up for surgery like that. But certainly with the more advanced techniques, with better surgical technique, with more comfortability with our vascular surgeons with this technique, I believe it's much lower. Okay, so that's ALIF. Now let's talk about a TLIF or a PLIF approach. And one of the advantages of this approach is that you can actually see the nerve that you want to decompress. And so this is a huge advantage in somebody with isolated foraminal stenosis at 5'1" and an L5 radiculopathy. And you don't think you can get it better with a microdisc because that is a very common pathology. And this is a perfect approach to just decompress the facet joint. And then you have to do the fusion, because you destabilize the segment. But if done in a judicious way, the patients have really good outcomes. So you can see when we insert the tube, we're coming at an angle. We usually make our incision about 3 centimeters lateral midline. We want to aim the tube about 25 degrees onto the facet joint. We want to see the lateral edge of the facet joint in the tube. And so if your tube is in the right place, then you know that all of the bony work that you're doing will lead you down the yellow brick road. It will lead you exactly to where the disc is. So we spend a lot of time in where the tube is placed. But if the tube is in the right place, then there really is no other collateral damage. If you look at all this other tissue here that is preserved compared to an open procedure, and you're just getting the foraminal stenosis better, which is that patient's only problem, then yes, you can get an outstanding clinical outcome if you pick the patient right. But the problem is that when we do a TLIF, I would say open or MIS, we take a lot less of the disc than we think. So this is one cadaveric study that looked at your handiwork. They had surgeons do a discectomy from an open approach, take out as much disc as they think that they took out, and then measure the percentage of area removed. And the best surgeons, removed about 60%, 60 or 70%. So that's why I always turn my eye a little bit when I hear folks say that they can take the entire disc out through an open approach unilaterally. Because it's just really, really difficult to do and maybe physically impossible. So I think if you are doing this procedure, you have to accept the fact that you're not taking all the disc out. And if you don't take all the disc out, you have to accept the fact that you likely will have a lower fusion rate compared to an ALIF, for example, where you're taking the entire disc out and you've got the whole surface area. I'm generalizing a bit there, but that's the reason why at least I think about ALIF versus a TLIF in terms of advantages and disadvantages. These are the reasons why we do MIS surgery. We're not going to talk specifically about this, but there are advantages. I would say that the advantages are short-term, maybe up to 3 months, but anything after that, as long as you do a good procedure open or good procedure MIS, you're really not going to change the outcome, past 3 months. But if you can do the surgery in just as amount of time, with maybe even lower risk, with less blood loss, a lower rate of infection, then you may be onto something. Then you may be onto a value-based decision as well. So the keys to success for a TLIF is that you want to avoid retracting the nerve root too much. There's no question that we have to retract the nerve root to some degree because Camden's triangle here is very small. And we have to be able to move the traversing nerve root and be able to protect the exiting nerve root so that when we put a 12 to 14 millimeter cage in, we're not shattering that, or we don't have any collateral damage. But when we retract that nerve root, we also have to be careful not to go too much because radiculitis is one of the most common postoperative complications that is unique to this procedure compared to something like an ALIF or a lateral or what have you. So that's how we try to minimize this type of complication. And then we want to avoid pedicle resection by our placement of our tube. and that you can easily resect the pedicle below if you think you're right over the disc space, especially if the angle of the retractor goes over the disc space or maybe tilted slightly caught it, and I'll show that in a sec here. So yeah, this is how we plan it preoperatively. Incision 3 centimeters.
Is that just him, or?
No, I think it's Dr. Sue. We'll give him a minute here.
The tube, and once you're in that position, in my opinion, that's the ideal place in order to generate the right corridor. A guide wire is, we don't use guide wires anymore, but we use dilators to help us find this corridor. And if you look at this foramen, we're basically trying to split the foramen with our retractor. And we also want to be in line with the disc space. If your retractor is offline, that's when you can get into trouble with the resection of the pedicle or other stabilizing structure. The actual steps of the procedure, most folks know, after we remove the facet joint, we then remove the disc, and then the preparation of the disc, insertion of bone graft with cage, and then finally screws. All of this is predicated and becomes much easier if your retractor is in the right place. So retractor placement is probably the key to facility with this operation versus needing to struggle with it. This is what the steps look like in terms of making sure that your retractor is in the right place. You can see my corridor here is in line with the disc space. It's appropriately medialized, which you can't see on this x-ray. It gives, and I know that if I remove all the bone in this area, that I should be safe, that I'm not going to resect any more than I need to. This is what the setup looks like. We won't go in detail here. That's Camden's triangle that we're looking at right here. It's more important, in my opinion, to see the traversing nerve root compared to the exiting nerve root. You can feel, although the majority of patients that we do this operation for is to decompress the exiting nerve root, you don't necessarily need to see it. You just need to make sure that you're decompressed all the way up to the pedicle, or at least you can feel all the way up to the pedicle, the superior pedicle, I should say. And then as long as you do that, then that's enough decompression of that nerve root in order to call it a day. Sometimes if you go after that exiting nerve root, not only does it put it into play in terms of an injury, but it actually allows that nerve root to come into your field when you're doing the T-lift. So I actually almost prefer it not to see it as long as I can feel it and feel that it's open in that area. And this is what it corresponds to on that cadaveric animated series as well. Okay. So these are just the steps here. Again, we're going to talk about some other procedures as well, so I'll move on here. It's critical when you put a shaver in to know that you're not too deep. When I first started doing this procedure, it was hard for me to gauge how deep the shaver went, and a few times I actually punctured through the ALL. And if you do that, it's not a big deal as long as it's a blunt instrument. What you want to do, if you do that, is you want to know that, and then you have to be very careful with all of your other instruments that grab, your curette, these things. You can still use them, but you have to almost measure them in your mind or put a mark on the segment itself to ensure that you don't go all the way through. But X-ray is very important to make sure that you're in the right space, especially when you're first starting this procedure. It's easy to get lost because you don't have a lot of landmarks. Okay, so this is the ideal patient. I would classify this patient with an MIS T-lift as successful as like a 1-level cervical disc herniation with an ACDF or a 1-level 4-5 disc herniation that undergoes a microdiscectomy in terms of the success rate. And so I never really learned this in fellowship as much, but I learned this later on that patients with foraminal stenosis can have very severe symptoms, and they can have severe symptoms with relatively mild pathology. And this is one example of it. So if you look here and then label all these, so this is obviously a sagittal view. This is the left foramen, and this is the right foramen at 5.1. You can see it's not a huge difference, but there is a difference, and I think it's just become nuanced more in my practice where I look for this. But if I'm looking here, that foramen may have some mild narrowing, but there's still a contour of that foramen that looks normal to me. And this one, this little bleb right here, is enough in my opinion when you correspond it here to the left side. And if somebody has L5 radiculopathy, and if you do an MIS TLIF for this patient, they're going to be one of the happiest patients in your practice. So I think it behooves one, and that's why I sort of hammer you guys when you're in the clinic, is to really look for the foraminal stenosis in a way that's nuanced. You can sometimes get fooled if you're looking too hard for it and then fool yourself into thinking that there is versus another. But especially if somebody has a dermatomal radiculitis in one dermatome and the central canal is totally normal, yeah, really look hard for the foramen, because I think I've seen a number of second and third opinions where this is missed, and a operation which is perfect for a patient, that falls through the cracks. This is another really good candidate for somebody with a MIS TLIF. And again, right here, this is the right side, and then this is the left side. There's not a big difference, but there is a difference. And so the right side, this patient had a previous L4-5 microdisc, didn't get his leg pain better, or had recurrent symptoms. And then you look here, this axial isn't that impressive, but you can see the foraminal stenosis on the sagittal that is not obvious, but is there. And if somebody has radicular pain in this level, and you can identify it and then do an MIS TLIF for them, again, I think these are slam dunk patients. Okay, but there are limitations of posterior interbody fusions. And so if you look at open versus MIS versus both, there are limitations for each. So pore surface area compared to lateral versus anterior, you're not going to correct deformity. There is nerve root retraction. There's post-op exposed. The BMP can cause radiculitis and cause heterotopic ossification. All these things can happen. And if you put it in a enclosed cage like ALIF or lateral, you're going to get a lot less complications. But it's because of these, and the pseudoarthrosis rate, in my opinion, would likely be higher compared to like a lateral anterior, just because you're not taking as much disc out. So to counteract these limitations, there are other options, such as the lateral interbody fusion. And these, in my opinion, these are the indications for a lateral, in my practice. Somebody with primary stenosis in a certain setting, a residual stenosis after a laminectomy, if you don't want to go into this scar bed, degenerative scoliosis to a certain degree, adjacent segment disease, pseudoarthrosis, and then even thoracic tumors can be treated through minimally invasive lateral approaches through the tube. The preoperative protocol involves measuring your cage length on your MRI and then looking for abnormal anatomy. So we recently published a study that showed that the vascular anatomy is a little more variable on the right side compared to the left side, and is more common in individuals with degenerative scoliosis. So if you have a scoliosis patient, it would behoove you to look at the MRI and to make sure that you know when the vessel is there or not. Now, I've heard surgeons say when a vessel does come around and is anomalous, that they would actually rather go on that side and enter the disc in that way, so that they know where it is and they are able to avoid it. I believe the opposite. I think there's a lot less opportunity to injure this vessel when you go in. When you go in the opposite side. So I'm typically going in on the left because I find the anatomy to be a little bit more predictable. But in any case, you want to look at the anatomy in any individual who you're thinking about doing a lateral approach for, because there are some clues as to individuals who are poor candidates. One option or one characteristic is this Mickey Mouse sign, when you see the psoas riding up, the nerve root or the lumbar plexus tends to ride up as well. And so we know that there's some patients that have anomalous lumbar plexus that tends to migrate anteriorly. And they have found that this sign is one of them. But I would say that it doesn't preclude me from going lateral when I see it, but I have a heightened alert when I do see it preoperatively on the MRI. Okay, so this is an old slide. I no longer use the bean bag because it is radio opaque and it has interfered with some of our imaging. So we just use a table. And this is an AMSCO table, and I don't break it nearly as much as I am right here. But basically, we do a gentle break in order to remove the ribs and the iliac crest out of the way. We secure the patient to the table, and then the operation really comes down to getting a really good X-ray and securing the patient in that orientation so that the operation angles are orthogonal. And I'll demonstrate that in a sec here. So these are the type of X-rays that you want before you start a case, and you want the patient to be positioned and the table to be level. And the reason is because when you're doing this operation, it's very easy to get lost because you can't really see anything. You're just banking on the fact that you're going in the right orientation and direction, but it's very easy to be off of 10 degrees, maybe 15, 20 degrees when you're preparing the disc, when you're inserting your retractor, when you're using your instruments. If you slip 10 degrees, we're talking about the difference between a vessel injury and being right through the disc. So that's why you have to use all of your landmarks that you have in front of you, including the table and including how the room is situated and how you're doing the operation. Okay, you mark out your incision with your guide wire, and then these are just a couple of videos that show, but basically all you need is an incision of about 2 centimeters over the level of the disc. We make an oblique incision for a 1 level, a longitudinal incision over a multi-level. This dissection is very quick. It takes about 2 minutes. You're bluntly dissecting through the oblique musculature, and you're coming straight lateral. So you're pushing the peritoneum forward, and you're entering the retroperitoneal space. And once you go through the transversalis abdominis fascia, then you're in the space and you're feeling the psoas. Now the OLIF approach comes oblique in it, and it comes at L5S1. And so there is a way to get around this peritoneum obliquely that will avoid the plexus, because the plexus can come anteriorly, and hopefully avoid the IBC, or the iliacs, I should say, that are anteriorly, and then take advantage of this area. Again, that approach is ideal for somebody who's getting both a 4-5 and a 5-1 fusion. We just don't do a lot of those, so I don't think there's a huge need, at least at our institution. But there are many other institutions that do a lot of 4-1 fusions for a variety of reasons. Okay, and then so once you're in, we use neuromonitoring, obviously, to make sure that the lumbar plexus is not in our way. And we need to do this because there are anomalies in terms of where the plexus lives. At L4-5, there's a much greater risk that there is an anomalous lumbar plexus. But typically speaking, if you're center on the disc space, then you should not be close to the lumbar plexus. This is a Medtronic system. We typically use NuVasive that has some more bells and whistles in terms of the retractor, being able to neuromonitor, and having a better secured retractor to the table. But the concepts are the same. Your retractor is in and over the disc space, and then once your retractor is in line with the disc space, then this operation becomes very, very easy. Like the rest of the operation is a piece of cake if you're able to get everything else right and orthogonal. Because once you see this, then it becomes just like any discectomy infusion. En bloc removal, you take your disc plate, disc prep tools, and then you insert your cage. But this is a very powerful operation, meaning that this exposure is enough for you to remove pretty much all of the disc. I would say that an ALIF probably provides a little bit more opportunity for lordosis because you're removing the ALL and because of gravity, and you can probably see a little bit better in terms of the disc because it's open. but you can remove a lot of disc through this approach, and especially with patients with a deformity, you can correct their deformity in a way that's even better than an ALIF, and I'll show a couple cases in that as well too. And so we want to measure, where the cob goes. So the last part of this operation, when you prepare the disc, is to use the cob to break through the contralateral annulus. This provides a much more flexible disc to put a larger cage in. You want to be careful of that in terms of, because you can use too much of it. But if you have this backstop before that, then you can remove disc without taking, or without having danger of going through the other side and injuring the vessels on the other region. And so this, we'll skip over this here, but this is what a cage looks like after you put it in. You want to make sure that your lines of your cage cover the pedicles on both sides in order for it to be stable. Okay, and then you can do multiple levels as well. This is an example of a 2-level. It's done through the same incision, and retractor time is key here. So if you have a retractor time of more than 30 minutes per level, then I think you run into a greater risk of nerve root retraction, nerve root injury, and symptoms afterwards. So when we are doing this operation, we're very critically, we pay critical attention, I would say, to how much time the patient's under retraction. Because even if you're on the nerve root and you do this question or do this operation quickly, you can still get away with not a permanent neurologic deficit or reducing the complications. So it's a great equalizer. Okay, let's come down to so this indication, in my opinion, is another slam dunk, but it's a slam dunk for the lateral approach versus we talked about TLIF. So the L3-4 isthmic spondy, and this is a patient that we probably did a year ago, and this is an individual with both back and leg pain. You can see there's foraminal stenosis bilaterally. She has bilateral leg pain, and she's got this isthmic spondy that makes it very flexible. And so whenever I've done an isthmic spondy in an individual with a lateral, you can jack this space up as much as you can with a lateral. And for that matter, you can probably do it with an anterior as well, but they're greater risk for the anterior than with lateral at this level. And so doing a TLIF is not a bad choice here, but there's just a lot more surgery with a TLIF, and there's a lot less opportunity in order to improve the biomechanics of this individual. So, and this is also at L3-4. So L3-4 has a much reduced complication rate when it comes to nerve root injury, plexus injury, exposure. I've heard surgeons say, and I would agree with this, that if you do a lateral procedure, but you don't do L4-5, you basically have a 0% chance of having a medical legal suit against you. And the only ones that I've seen and I've experienced, or I've come in contact with, are ones at L4-5. And so because there's a greater chance of an injury there. And so this individual, this is what she looks like post-operatively. We got this MRI because of some new symptoms about 6 months later, but you can see that the central canal is much better than it was in the preoperative X-ray, and there's no foraminal stenosis as well. Okay, so and these are just other cases here. This is an individual with a primary stenosis. She was 80, and she had neurogenic claudication, but she had a 2-level degen spondy, and she also had degenerative scoliosis. So I felt like the lateral interbody could improve her scoliosis, could improve her stenosis through an indirect way, and I'll show a study that kind of shows that, and is a more minimally invasive approach than an open decompression infusion posteriorly. One could argue that you could do just a laminectomy on this individual, but I thought she'd become unstable at that 3-4 segment, so that's why I chose not to do that. But so in this individual, these options are all reasonable, but we decided to do the lateral approach to minimize blood loss and got a good result. And I feel like her degenerative scoliosis was improved, which was part of the issue, that caused her pain. So the studies, the evidence based literature shows that if you look at pre and post-operative MRIs for folks with a lateral interbody fusion, and you measure their disc height, foraminal height, area, and canal diameter, that you're going to get a significant improvement of all of these after you do a lateral interbody fusion. And so that is the concept of an indirect decompression. So looking at this right here, the left here is pre-op and the right is post-op. So for individuals who don't believe that indirect decompression can decompress the canal, you just need to refer to a couple of these studies to show that you can actually achieve this. Now, it only works though in an individual with a collapsed disc space and or an isthmic spondy. If you have somebody with a very tall disc space and a very narrow canal, the likely reason for that narrow canal is congenital stenosis, because if it's not coming from the disc, the other option is that the patient has short pedicles. If you do a lateral interbody fusion in that patient, you're not going to get any decompression of that canal because you're not going to gain any more height than that patient had already. So an important distinction to make. Okay, and then you got an individual like this with residual stenosis. So this guy was 71, neurogenic claudication, had a laminectomy 4 years ago, and you can look here. This whole bed is full of scar tissue, and he still has stenosis at 3, 4, and 4, 5. But he got better from this 4 or 5 epidural injection. So, and he does have a small dynamic component to his spondy, I would say. So in this individual, you could go in from the back again, which would be a mess, or you could try a more indirect approach, and or you could go through the front. But going through the front at 4, 5 and 3, 4, there are just more complications in that area than going lateral. So lateral, in my opinion, would have a reduced complication rate when you're talking about this kind of patient. So we did a 2-level lateral on him for residual stenosis, and then got a good result. So again, let me go back here. This patient has collapsed disc spaces, right? And so the reason for his stenosis is because of the disc. So if that's the case, then improving the height of that disc, it makes sense that could provide you that indirect decompression. Adjacent segment disease is one that I feel is also a good opportunity for a lateral. This is an individual with adjacent segment degeneration after an L4-S1 posterior lumbar interbody fusion. I think it's a slam dunk if you can just do a standalone lateral. I think the instrumentation now is better than what we used to have. I used to just put a P cage in and then brace them for 6 weeks and then hope for the best. And I had very few that migrated, but more recently I have had a couple. This is an individual where there was no migration. We got a good sized cage. We just did a lateral approach. It was essentially an outpatient procedure. And I think there's a lot of advantages here if you don't have to go through the back. This patient achieved a fusion maybe 3 months afterwards. Okay, so degen scoli also can improve from both an ALIF and a lateral. So this individual, I sort of combined approaches, and it'll become apparent why when I talk about the characteristics. So he's a 63-year-old gentleman who had low back and hip pain, many years of pain, but really not a lot of leg pain. Most of his symptoms were in his low back, and he's got the scoli. He failed conservative management, and you can see the curvature here and I got some parameters here. It's not the worst curve in the world, but about 43 degrees on a Cobb angle, and then lordosis is 57. You can see otherwise relatively well balanced pelvic incidence, pelvic tilt 13 degrees, sacral slope 39. So we're not talking about a huge mismatch here, and there's not a need for like an osteotomy or anything like that, in my opinion, when you've got parameters here that are relatively well balanced. Not a huge sagittal balance issue. So, and then if you look at his, canal, not a lot of central stenosis as well. So we're really aiming to correct his degen scoli to correct his back pain. And so minimally invasive approaches here without an open decompression, I think, does have some advantages. He's also got a 5-1 spondy, which we got to fix as well. So here are your options, many different options, but we chose to go from the front at 4-5 and 5-1. So treating the isthmic spondy, also treating the lordosis, or restoring the lordosis from 4-1, and then later that day going to a lateral approach at 3-4 and 2-3. Now we're correcting the scoliosis because we got to correct that problem. And we went, so this one we actually went through the concavity. It was on the left side, and there was no vessel anomaly, so that's why we chose to go through this approach. And then you can see the reduction of scoliosis. It's not perfect, but there is definitely improvement of the scoliotic curvature, insertion of the cages, and then percutaneous screws. And so this was an operation that took 3 different approaches, but overall, the blood loss was almost minimal. And percutaneous fixation, we were able to improve his curvature by doing these minimally invasive approaches. So I do think that there's a role for the minimally invasive approach in somebody with scoliosis, but it's limited, because I think that anybody who has like a positive sagittal balance, for example, that's way beyond something you can correct from an ALIF, really would not be a good candidate. Okay, and so I'll end by just talking about a couple of complications. So lateral interbody fusions have a unique set of complications to their own. There's psoas weakness that everybody gets, potential nerve injury, bleeding, pneumothorax, when you're talking about doing a thoracic type level, and then you can have cage complications as well. This approach warrants that it's an anatomy that we're not used to. The psoas overlies the disc space. The genitofemoral nerve sits along that psoas nerve. We can't even see the plexus, so we need to monitor it. The ilioinguinal nerve and femoral nerve can also come into play. And if you aren't careful with your preoperative planning, the large vessels can come in the way. A segmental vessel can come in the way if you're overlying the vertebral body and not overlying the disc space. And then one can get a retroperitoneal hematoma. This study is a much older study now, but it shows that if you look at the L4-5 segment, that up to 28% or 30% of individuals can have their lumbar plexus migrate anteriorly, but this is much less common at L3-4, L2-3, L1-2. Everybody gets hip flexion weakness to some degree. Most folks are better at 6 weeks, or completely resolved at 6 weeks, I should say. But other individuals can have thigh pain, they can have thigh numbness, and so I tell everybody that they'll get this and that they may have trouble walking for a few weeks. But most of the time, it's not really an issue. We talk about genitofemoral nerve injury. I've been seeing this on the OITE. This presents with paresthesias in the anterior thigh, perineal area, groin pain. The sympathetic chain is located along the antero aspect of the vertebral body. You have to be way off to really get this. This is more commonly seen when you do an ALIF or do like a retroperitoneal approach with an open approach. The dreaded vessel injury. So we don't really use this anymore, but we used to put these pins in the vertebral body in order to hold that disc open, and the segmental is certainly at risk when you do that. And but more often than not, I've seen it a couple of times, and you can often just tamponade it. It does not require a vascular surgeon in order to repair it, even if you get that. And then, so the dreaded complication is the vascular injury, because if you get a vascular injury, you most likely do not have very good exposure, and it's very hard for a vascular surgeon to get there in time in order to save the patient, especially if you've gotten it from the other side. So want to be very careful where the retractor blade is, very careful where the vessels are. And this is just one report of a fatality that occurred from a lateral approach at L4-5 incidentally, and it was when the retractor blade slipped anterior to the disc space and injured the vessel. One of the things that I didn't know could happen was that patients can get an abdominal wall paresis. And I've seen this a couple of times where they have this pseudo hernia, which is a flank bulge. It's painless, but the reason it occurs is that there's a splitting of the intercostal nerves that can denervate the abdominal wall in that area. And so this almost always resolves, over like a 6-month period of time. But patients may complain about it, and they have in the past. I remember I had to look this up because I'd never heard of it. But this is very common when you look at a retroperineal approach, like for a kidney surgery, for example. And so this is one version of that. Okay. We did this. So this is a study that I referred to. Gosh, this has got to be like 5 years ago now. But we looked at a lumbar spine MRI for anatomic structures within the corridor. And this was how we concluded that the right-sided vascular anatomy was more variant than on the left side. The older you were, the more likely you'd have anatomic variation. And if you have scoliosis, the variant anatomy is on the convex side. So better to go through the concavity of the curvature if you have a choice. And these are just examples from the paper as well. So, okay, so I'll just end with this. One of the most daunting complications from this operation is that you can oversize the cage. Because this is so powerful of an operation, and you can take so much disc out, and you can actually jack up the disc space, you could actually cause adjacent level problems. So if you look at what's happening here, on the left, this is 4-5. We did the operation at 3-4. And immediately post-op, I just caused this adjacent segment degeneration. And so after doing this for a bit, I've realized that you don't have to size the cage as much as it goes, because there is a danger. And that's not even to say like subsidence and vertebral body fracture, all these are probably increased with that as well. So you want to go on the low end in terms of cage placement or cage height if you can, because you can lead to this issue. Okay. I'll end there, and let's open it up for questions.
Hey, Wellington, that was great. A lot to cover, as always. Let me take one step back and ask a question, or give a comment and then ask the question. The comment is, as I sit and I examine for the boards now, it is almost unheard of that every single case is now an interbody fusion. Everything's a TLIF, lateral, OLIF. Maybe just speak a bit about where we are with regards to evidence on interbody fusions compared to posterolateral fusions. And when are we doing interbodies? When do we think we don't need them? What do you think about that situation? Yeah. And then the reality of our clinical practice?
Yeah, so it comes down to what we talked about. Can you still see my slides or no?
Yep.
Okay. So we have to think about when an interbody cage is indicated. And so I agree with you that we're doing many more interbodies now than we used to be, but not everybody needs an interbody, and the evidence certainly suggests that. I think that older patients don't need an interbody. I think older patients with with a degenerative problem, with neurogenic claudication, they need a posterolateral fusion at most. And there's no reason why we need to subject them to higher cost and higher rate of complications. I think that patients who have an MIS surgery, if we can't do interbody, I don't really know how to do an MIS surgery for them. So I think for individuals who are candidates for MIS, you almost have to accept the fact that an interbody is somewhat indicated in order to get a fusion. I would say that the younger individual, it'll be hard to show a study because you need like 20 to 30 year follow-up. But in a younger individual, it's much better. I would certainly consider an interbody fusion more because a pseudoarthrosis in that patient is going to be more likely to cause a reoperation than an older patient. So that's how I think about it. So age, MIS, and for those who I need a fusion in. Everything else, like deformity, like everything else that I covered is in theory. I try not to talk myself into doing an interbody for that indication alone. But I feel like I can hang my hat on those, and I think there is some data to support it. I don't think there's a lot of data, but I think there's some data to support it. So that's where I would go with that. What about you, Al?
Yeah, I mean, I similar things. Like the only other factor that I think about against interbody fusion, one is osteoporotic patients or osteopenic patients, because I think those subside, unless you want to go lateral or you want to go, ALIF, you're going to get subsidence. And then the other group is folks with multi-level fusions who, if you do like if you start doing like a 3-level MIST lift, the amount of time and effort you spend on that and the amount of anesthesia time starts to become a little overwhelming. So for those folks, I still like the idea of a straightforward, midline open LAMI and posterolateral fusion in that setting. But again, I am amazed at how oftentimes, and again, this is for the resident and for Sri, that it's amazing how oftentimes I'll see folks do 3-level T lifts or 4-level T lifts in that same setting, where in our practice, we would just do a posterolateral fusion. And the argument that I hear at the boards, which I love when people say this, is usually one of two situations. One is, well, I wanted to get a better fusion. Okay, like where's the comparative data between an interbody fusion and a posterolateral fusion? It's in that setting, it's almost non-existent, right?
It's non-existent because of the follow-up we have, but yes, it's non-existent though.
Yes. But they'll say it with confidence because that's sort of, again,
right.
And the other one is, well, I wanted to get foraminal height so I could decompress the foramen. And I get that, totally agree. And actually, Wellington's convinced me that indirect decompressions work. When I got here and I saw you doing this stuff, I was like, there's no way that works. You're revising all of them. And we'd watch and we'd see, and they actually did pretty well, right?
Yeah.
But I also challenge back is, I always love this question, is there another way to decompress the foramen?
You mean directly?
You'll see these folks, like, you'll see these surgeons like, well, I could go ALIF, or I could go lateral, or I could go OLIF, or I could go, and and then you're like, well, can you just also just do a do a fastectomy and decompress the foramen? Oh yeah, of course you can. So, don't forget, you're going to hone in when you're fellows and when you're in early training to do the biggest procedure you can, or the most technically advanced procedure you can. But you have those options of doing doing instrumented posterolateral fusions. I haven't done an uninstrumented case in a long time, but those are also still options. And we just don't talk about it because the x-rays don't look as good and there's not as much to cover, but they do pretty well.
Patients can still do well with that. Yeah. I mean, as long as you do decompression, right? So
they can. The only other thing I was going to ask you about is for the laterals. Now I've been using, I've been putting a screw into them. I've had a couple of them over the years where they shift just a little bit.
Yes.
I'm not sure if you've seen that, but I've had that happen. So now I try to put a plate and a screw, maybe 2 screws to hold it in place.
Yeah. You actually convinced me that the newer instrumentation is better than the old. I think, when they first came out, all of the backlash was that these screws would break, plates would break, and there'd be migration problems. But the newer instrumentation, I think, is much better. And I think NuVasive in particular has figured it out with a plate that you can attach. That is not very proud, that gets good purchase. And so, I've used it a couple of times. I think I don't do a ton of standalones as much as I used to, but I think in this standalone setting, that's a perfect adjunct.
And then the last thing I was going to ask you about is, because it's sort of a hot topic now, is this prone transpsoas. What do you think? Maybe I'll ask Sri, because Sri was all excited about it. I want to hear what he thinks.
So I'll give my 2 cents and then we'll go to Sri.
Okay, go for it.
So I feel like our table like the turnover time, especially in my cases, you're not saving a whole lot of time, because I feel like they're pretty quick with it. So I see advantages in doing that, but I don't feel like I get held up that much with the table turn. So that's why I haven't been totally gung-ho about it. Sri?
Yeah, I think it would be useful for like for example, the examples that you put up, the degen Scoli patients, where you're thinking about like a 2-3 level front back instead of like a true AP or the lateral P. People have been trying to do those in like the single position lateral position, and doing this prone would make it a lot easier than trying to do those down screws in the lateral position. That I think is advantage. That being said, if the teams are good enough to like minimize the issue with the flip, then that's good. The other good point I think other people brought up was that like with anesthesia, it depends on the anesthesia team. Like if especially like APs going front back, people, if they're picky with their lines and they just take a long time to kind of organize things. If you just have one person in one position, everything's in set place with anesthesia, they literally have no idea what you're doing. You could be in the anterior column, in the back, putting screws. And then that's the advantage I see. I mean, I think it'll probably be just like a few patients a year, maybe it might affect, but that's what I was seeing. It could be kind of a game changer for that setting.
Yeah.
But
You would need navigation for that, right? At least it makes sense to me if you were to do that, to use navigation for that purpose.
for the posterior screw placement, or
Yeah, prone lateral. But
you're right.
use X-ray or I mean, I guess you could use fluoroscopy for it, but
Yeah, I think
For-
we're
for-
based right now.
Yeah, the fluoro case for the cage placement.
yes.
I think it's all fluoro based still, and it's actually less of a hassle to use fluoro for that, it seems, because there's just less flipping around from lateral to AP, and the kind of the ease of having the radiology tech kind of work with it is easier, so it might cut down a little bit of time there.
Yeah, I would agree. I think it's interesting. I think there are these unique cases. For me, it's not about the L2-3 degenerative disc that people are doing, laterals on now for. It's that patient who needs like a 2 to 5 for a degen scoli and stenosis. And could I do my work, decompress them, release the facets, and then maybe put those laterals in if I feel like I'm going to get a better fusion rate with it. But again, I feel like the posterior laterals do pretty well. So what am I gaining, here? So it's a bit of a circular discussion. I'm going to count on Sri to start doing them, get all the complications in the world with them, and then once he's figured it out, he can teach me how to do it.
Put together a great talk.
That's right. We'll write all the papers on it.
Hey, one last thing, and I know we're over time, and I got to get my helping my kids here. For the anterior exposures, this is just for everybody, but specifically Wellington and Sri. I did an ALIF with the new general surgeon, the new trauma surgeon, who's the chair of general surgery, Hassan Alam. He was doing all the spine exposures for the team at Michigan. And so we did a case with him last Friday, and speak up, Waji, if you saw otherwise, but I thought it all went, pretty well. And he's a little bit more interested in making incisions smaller and in trying to be a little bit more speedy, although I don't know that happened, but he certainly was more open to the idea of smaller incisions and trying to be more available so that you can have some flexibility with your scheduling.
Oh, good. So he's amenable to the anterior approach still.
Oh, totally. He wants to do them. He's like, it doesn't have to be the first case start, so you can get other cases in first and then do it. And again, it was a different experience with him than with vascular. It's also like not everything's a AAA, so you don't have to expose, all the way up and down. And so just keep that in mind. If you guys want to work with him, he's open to it.
Cool.
Nice. Hey,
All right, man, thanks so much for your talk.
One question. Sorry, Alpesh, you can start off one, but I just had one question for Wellington. I like the pictures that you showed, and I think I'm becoming more of a believer in indirect decompression too. What about, foraminal height restoration is easy to see kind of in the OR and believe in, and then the indirect decompression, I think there's enough these studies with the post-op MRIs, you can kind of see that. What about that kind of in between the degenerative spectrum, like the lateral recess stenosis, people with some foraminal, like they have one level disc collapse. Obviously that collapses a foramen. Their facets are hypertrophying, causes some lateral recess stenosis, mild disc bulge. You still try to decompress those first, or would that be candidate for like a lateral or an ALIF. I got, it's like my guy tomorrow is exactly that.
You doing a decompression on him?
Yeah, just like an open Lamy and then try to bite under the lateral recess.
Yeah, I think in that individual, that's an accessible pathology through a micro decompression or a McCullough, right? Like you can just take a little bit more, just go a little bit more lateral. That patient will do better, in my opinion, with a outpatient micro decompression than a lateral. I think laterals, yeah, like if somebody has central stenosis, I believe in the lateral indirectly decompressing it, but that's not my number one patient. My number one patient would be a foraminal issue, ismic spondy, right? Like that's your slam dunk. That's when you have to fuse, and especially at 3-4, there's like, the risk complication ratio is much lower. So, but if lateral recess stenosis, yeah, at 4-5, yeah, just micro decompress that guy. I don't
Yeah, I think that makes sense.
But to your point, Sri, that I was, again, the foraminal stenosis, that's an easy belief. Got that. Lateral recess stenosis, kind of believe it as well, right? Because you get some restoration of height, you get some maybe realignment of the facet a little bit, maybe. I was always a skeptic on the central stenosis patients with like the thick flavum and the overgrown facets, and so I wouldn't do it, and I wouldn't do it. And then I had a couple that I tried it on, and I would tell them, hey, if this doesn't work, we're gonna have to open you up and we'll do a standard open, Lamy fusion. And the number that I've had to take back to revise posteriorly is really small. I can think of like 2 people who I was on the fence about for a lateral, and then they've ended up doing really well. Those are usually adjacent level patients, by the way. Those are usually like, L2, 3, 3, 4 adjacent segment. And I haven't had to take them back, to Wellington's point. They seem to do pretty well. I've even seen folks where I get great height back post-op and then they subside. And they're still okay. Yeah, it makes no sense to me.
Yeah.
Because anything we gained in the OR, in theory, we just lost it by 6 weeks. And yet the patients feel great.
It's your bedside manner.
It's interesting.
I don't know what it is. Maybe it's just, it's placebo, or maybe it's the stabilization they really need.
Yeah.
Right? Maybe it's the stability that benefits them as opposed to I don't know. But I've liked it as a first option, with the idea and the clear conversation and the consent process of a possible posterior. Yeah. All right, I'll let you guys keep talking, but I got to run. I'm so sorry. Thanks, Wellington.
Yeah, no, thanks, Al. Anybody else with questions? Everybody good?
Actually, one quick question. In terms of talking about the power of, like the A-lift to really dial in lordosis, what about an X-lift with like an anterior release? It's obviously dangerous and not commonly done, but I mean, if you pursue, releasing the ALL as much as you safely can, do you feel that you can get more of a lordotic correction with a lateral approach?
The answer is yes, Waji, and there are definitely some cowboys out there that have demonstrated that it can work, and that's why you got your hyperlordotic cages. But I have a real concern with, I just think if you're doing something like that, you're introducing another level of complication, and if you get a complication, a life-threatening one, right? Like, because you don't want to get a vessel injury in a tube, where you just have a tube, unless you got like a vascular surgeon sitting in the next room ready to, crack down that patient. I just don't know if it's worth it. I think if I really wanted to get that much lordosis, I would just go from the front, ALIF, and be more, I guess, have a better controlled environment. But I've seen some pretty cool X-rays from individuals who are willing to do it. You just got to get that malleable all the way around the front. It is a blind cut. They talk about pie crusting the ALL and not being able to see the last 2 and just hoping that the vessel is covered by your malleable. I don't know. I don't think spine surgery should be like that, right? You don't really have to make it that way. So it's definitely pushing the limit, and there's definitely some options there. I just haven't found the real reason to subject that patient to that complication, that risk.
What about interbodies for adult spinal deformity? I know a big thing on the interview trail is places where they do like multiple laterals instead of doing like a PSO. What are your thoughts on sort of the old school traditional technique versus multiple level interbodies?
Yeah, so I think in the patient I showed, somebody with a coronal deformity that's relatively well balanced sagittally, that doesn't have a mismatch. Yeah, that patient in a lumbar area, let's say L1 to S, like my patient was like L1 to S1, really, not a lot of compensatory curvature, right? That patient, yeah, definitely, you can get away with interbodies. I think you have to accept that you won't necessarily resolve their deformity completely as you would with like multiple SPOs or maybe a PSO. That patient wouldn't need a PSO, but just like multiple SPOs could do it. But yeah, if you got somebody with sagittal balance issues, and that can't be corrected through an ALIF, then that is a PSO in my opinion. Somebody with a thoracolumbar curvature that needs to be fixed. I think you really shouldn't be thinking about MIS. Although you'll hear about, you'll hear Neil Anand talk about and Michael Wayne talk about how all their patients are corrected like to a level. I just think it's very difficult to do it on a large scale. So yeah, but the patient without positive sagittal balance and without mismatch and coronal deformity, yeah, absolutely, you can do interbodies so the cows come home. Yeah.
Dr. Stu, I just had a quick question about
Yeah,
the
Peter.
interbodies themselves. So, ALIF and lateral, it seems like the footprint of the interbody is, large compared to posterior when you're going posterior. And I just wondered if that affects your fusion rates, or Dr. Patel mentioned subsidence maybe in the osteoporotic patients. Like, what are the considerations there on just the size of the interbody itself?
Great question, Peter. So a lateral and an ALIF, those cages are large enough to where the struts of the cage are along the apophyseal ring because they're so wide. And so I think a subsidence issue with that cage is less likely to occur than a TLIF cage where it sits within the disc space. You're basically end plate on, cancellous bone on the actual strut itself. And so there's a huge opportunity for that to subside, especially in an osteoporotic patient. I think the ALIF and lateral get better fusion rates because of what you alluded to. A larger cage, more surface area, you can put more bone graft in, you're taking more disc out, and oftentimes we're putting like a screw like in its immediate stabilization. Now TLIFs, in my opinion, still fuse very, very well, but they won't have a comparable rate to an ALIF or a lateral. Now, these studies won't show that because the effect size of that is so small. It's not going to be like 90% versus 60%. It's going to be more like 95 versus 85, something like that. And then you need 1,000 patients over to show that difference, right? So you're not going to show that with a study. But I'm telling you that it makes sense to me that a larger cage with a larger footprint will lead to a better surface area, or more surface area, and increased fusion. It just theoretically makes sense to me. Yeah. All right, anything else, guys? All right, great.
Thanks a lot, Dr. Stu.
Yeah, thanks. A great lecture. Bye.
See you guys tomorrow.
See ya.
It was awesome. Thank you, Dr. Stu.
You're welcome.
And then it was just the boys. All right, I'm signing off.
Oh God, let's do that now.
Yeah, we go to Timmy's.
Round two.
Round two. All right. See you guys.
All right, see you guys.